Good afternoon. My name is Cristina Rodriguez, and I'm a PharmD candidate from the Ben and Mady Fish College of Pharmacy. And we're presenting a journal club today, and I'd like to introduce my audience.
Cristina, Becker Garcia. I'm Andrew White.
Thank you guys so much for participating in today's journal club. The topic will be over the JAMA article that came out in 2019 titled Effect of Bempedoic Acid versus Placebo Added to Maximally Tolerated Statins on Low-Density Lipoprotein Cholesterol in Patients at High Risk for Cardiovascular Disease. The Clear Wisdom Randomized Clinical Trial. So patients with clinical ASCVD, the guidelines currently state that they should be on a high intensity or maximum tolerated statin to lower their LDL-C levels. For some patients who are currently on a statin therapy, sometimes a statin therapy alone is insufficient, so the guidelines advocates for an add-on therapy of non-statin agents such as ezetimibe, bile acid sequestrates, and PCSK9 inhibitors. So ezetimibe is what we currently see the most in practice. Bile acid sequestrants, they're associated with a lot of GI complaints and can potentially cause severe hypertriglyceridemia whenever the fasting triglycerides are 300 or greater. PCSK9 inhibitors, they're the most efficacious out of those three at lowering LDL-C levels. So despite there being numerous agents that can be add-on therapies to statin, we typically do see high LDL-C levels in patients that have ASCVD or heterozygous familial hypercholesterolemia, and they're not able to achieve appropriate LDL-C levels. So because of this association with lowering LDL-C levels and reduction of cardiovascular disease, it supported the development of a new drug to lower lipid levels, and one that could be used potentially in conjunction with statins or other current therapies that we have. So thus led to the creation of bempedoic acid. It is an oral agent that is taken once daily. It is the first in its class, and the mechanism of action is it targets, so it's a prodrug, and once it gets activated in the liver, it inhibits ATP citrate-lyase, which is an enzyme that is 2 steps upstream from HMG-CoA reductase, which, as we all know, is the target for statins. So essentially what it does, it inhibits cholesterol synthesis. There have been previous trials for this drug, such as the Clear Harmony one, and the objective of that was to determine the safety and efficacy of bempedoic acid compared to placebo. So the objective of this study was to assess the efficacy of bempedoic acid compared to placebo in patients who are high risk of cardiovascular disease and who are also receiving the max tolerated statin or max tolerated lipid lowering therapy. So as a primary endpoint for this trial, they had it was percent change from baseline to percent change in baseline LDL-C levels from week to week 12. A secondary endpoint was the percent change from the baseline to week 24 in LDL-C levels and to week 12 in other lipid biomarkers such as non-HDL-C, total cholesterol, ApoB, and hsCRP. Tertiary endpoints were to continue evaluating those markers up to week 24 and week 52. So the design for this study was that it was a phase 3 randomized, double-blind, placebo-controlled clinical trial. It was conducted from November 2016 to September 2018. Patients were screened at 91 different sites that were located throughout the North America and Europe. Out of those sites, 86 of them randomized patients to the study treatment. Randomization was performed by using an interactive web response system, and they stratified these patients based on the presence of whether they had heterozygous familial hypercholesteremia and based in their baseline statin intensity, so low, moderate, and high intensity. Patients that were not receiving a statin therapy were included in the low intensity group for stratification purposes. Inclusion criteria included that they had to have a high cardiovascular risk, which meant that they had to have a diagnosis of either heterozygous familial hypercholesteremia or ASCVD, or both. They also had to be on a max tolerated lipid modifying therapy, and their fasting LDL-C level had to be equal to or greater than 100. Exclusion criteria was triglycerides 500 or greater, renal dysfunction, categorized as EGFR less than 30, a BMI greater than or equal to 50, and significant cardiovascular disease or a cardiovascular event that occurred within the past 3 months. So patients were randomized 2-to-1 to treatment. So about 2/3 of them received the bempedoic acid 100 milligrams every day, and the other third received a placebo for tablet every day for 52 weeks. Both groups continued to remain on whatever lipid modifying therapy they were originally on. So as far as the statistical analysis, they plan to have a sample size of about 750 to estimate to provide like a greater than 95% power to detect a difference between 15% in LDL-C between the groups. This calculation was based on a two-sided t-test and had a 5% level of significance with a standard deviation of 15. So each of these hypotheses were tested, and they're two-sided with the statistical significance of 0.05, and they also tested those other lipid parameters that I mentioned earlier that were the secondary and tertiary endpoints. No imputation was performed for the tertiary efficacy endpoints, and they also did analysis within each of the subgroups. So if they had, they did the subgroups based on cardiovascular disease category, so if they had ASCVD or the heterozygous familial hypercholesteremia, statin intensity, LDL-C category, and their region. So those are the different subgroups that they had. They also conducted numerous post-hoc analysis. So they did it between the type of like lipid lowering therapy and whether patients were under glycemic control. And they also did mixed effect model with site as a random effect to evaluate the study site on primary outcome. So all the statistical analysis were performed using a SAS version 9.4. So all the tests were two-sided with a significance level of 0.05. Overall, all of their statistical analysis for the trial was appropriate, especially since they divided the different subgroups and analyzed them from there on. So some of the results from the trial, the baseline characteristics, if you refer to figure 1, you can see that all of the patients that were screened, only 779 of them were randomized. The median the population was predominantly white males, and most patients had ASCVD without heterozygous familial hypercholesteremia. And there was a mean baseline level of LDL-C of 120.4. And a majority of the patients were receiving some type of statin therapy, and with about 5% that were not taking a therapy at baseline. So for the primary outcomes at week 12, bempedoic acid, you can see it's significantly lowered the LDL-C levels compared to placebo at week 12. So bempedoic acid was lowered approximately by 15.1% from baseline compared to 2.4% with the placebo group. It had a p-value of less than 0.001 with a mean difference between the groups of negative 17.4. Had a 95% confidence interval from negative 21 to negative 13.9. So all of the statistical values that they got from the trial are statistically significant and clinically significant. So at week 24, you can see on the figure that they continue to observe the similar decrease in LDL-C levels from the 12-week mark. So at week 24, the LDL-C levels remained reduced by a negative 12.1% in the bempedoic acid and 2.7% for the placebo group. And that was actually an increase. So it increased in the placebo group and decreased in the bempedoic acid group. And there are significant reductions, not only with just the LDL-C levels, but with all the other lipid biomarkers. And those were maintained through week 52, as you can see through figure 2 and table 2. So for the post-hoc analyses, they saw that there was no, overall, between the different subgroups, there's no like change, or there wasn't anything that stood out. So across the board, all of the reductions in LDL-C levels remained the same between the subgroups. They also detected no effect of the different study sites that was used. So overall, all of the results between the 91 sites were congruent. So the common adverse effects that they did see were nasopharyngitis, UTI, and hyperuricemia. And the author's conclusion for the trial was that patients who are high risk for cardiovascular disease while receiving maximally tolerated statins, the addition of bempedoic acid compared to placebo was significant in lowering the LDL-C levels over 12 weeks. The researchers, they believe that further research was needed to address durability and the clinical effect and long-term efficacy. So my conclusion is that I do agree with the authors that the bempedoic acid significantly lowered the LDL-C levels across all subgroups. Some of the strengths from this trial was that they had an appropriate population size, because their goal was 750. They had 779 in this trial. And I also thought it was very appropriate for them to have added patients who, if they currently weren't on a statin, maybe the max tolerated statin for them was no statin. They also included those patients in the trial. So patients who were not on a statin or were on some other type of therapy, non-statin therapy, they were also included in this trial. All of the statistical analysis that they performed were appropriate and showed that it was statistically significant and clinically significant. Some of the weaknesses from this trial was that they did observe and monitored the administration of bempedoic acid in placebo. However, they didn't monitor whether the groups were continuing to take their current lipid modifying agent. So because they weren't monitoring it, that could have affected the LDL-C or the lipid biomarker results that we see in this trial. So in the future study, I'd probably recommend that they also monitor those patients who are taking statins, making sure that they take them daily or on whatever non-statin therapy they're on. Secondly, the trial, it was only 52 weeks. So I believe that for further data on like long-term efficacy and safety, they'd have to have a longer trial with even more patients in it. So I do think that this trial was necessary and applicable because we do see patients who have severe dyslipidemia despite being on statin therapies or non-statin therapies. We do see consistent LDL-C levels that are elevated, and a new agent like this could be beneficial in helping the reduction of that and potentially helping reduce cardiovascular risk. And I also do think this is applicable since it was conducted in North America, so we did have a lot of sites here. At this time, I'd be happy to take any questions.
A few questions for you. So, what is the mechanism of action of bempedoic acid compared to acetamide?
Okay, so bempedoic acid, it's a prodrug that gets activated in the liver, and it inhibits ATP citrate lyase, which is an enzyme 2 steps upstream from HMG-CoA reductase, which is the target of all statins. And so essentially what it does is it inhibits cholesterol synthesis, whereas ezetimibe inhibits the absorption of cholesterol from the intestine. So it decreases the amount that's absorbed and leads to cholesterol absorption that is currently circulating in the body, thus decreasing overall levels of cholesterol.
Okay.
I have a question. You mentioned in the beginning of your presentation that PCSK9 inhibitors are effective. Why not use that medication instead?
So PCSK9 inhibitors are monoclonal antibodies, and they're really effective. So they're up to 60% effective on average. However, they do have to be administered subcutaneously, and they've been historically expensive. So anywhere from like $1,000 a month without insurance to approximately $400, $500 with insurance. So they're still pretty pricey, and patients typically prefer oral agents over injections.
And I have a question for you. Is bempedoic acid FDA approved?
So no, it's not currently FDA approved. However, they did submit a new drug application on February 20th of 2019. So they submitted one for bempedoic acid, and they also submitted one for bempedoic acid with combination of ezetimibe.
I say thank you.
So my question is, are there currently any other trials for this drug?
So yes, there's currently another trial called Clear Outcomes. And that one, the objective of it is to see if bempedoic acid could reduce CVD. And that study, I think they're currently taking patients, and it's being conducted right now. So you won't expect to see any results until like 2022.
Do you think that this drug could potentially replace statins in the future or just supplement?
No, I don't see this drug replacing statins in the future because we've had so much evidence on statins and they've been such a mainstream for dyslipidemia. However, I do see this potentially being beneficial as an add-on therapy treatment, especially because it doesn't activate or target the skeletal muscle.
Okay, thank you.
Thank you.
Thank you, everyone.